Welcome everyone to the KPC channel. This afternoon, I'm really excited to have an interview with none other than Dr. Suresh Kumar, who is with the WHO Collaborating Center for Country Capacity Building in Palliative Care and Long-Term Care. He's with us for this full week in October to do a series of workshops for us and roundtables on how do you build a compassionate community centered around community palliative care. So before I start the interview proper, maybe I would like to invite Dr. Suresh to say a few words.
Thank you. Thank you for the introduction. I'm Dr. Suresh Kumar, a palliative care physician, active in the field for more than 30 years. And currently I hold the position of the Director of the World Health Organization Collaborating Center for Building Country Capacity in Palliative Care, advising the WHO and member countries on how to build palliative care services.
So Dr. Suresh, you've been a pioneer in bringing palliative care to the community in Kerala and other communities around the world. May I ask, what was the spark that ignited this passion in you and what kept you going in the face of many challenges in setting up IPM, which is the Institute of Palliative Medicine?
Yeah, actually I started I was trained as an anesthetist to start with. That was my medical background, and then I started seeing patients with pain as part of my anesthesia practice, and then many of them were people with advanced diseases, many of them were people at the end of life. And when I started talking to them and examining them and actually treating them, I started to realize that this is actually in fact a marginalized group, because whichever be your position before that, once you are diagnosed to have to be at the end of your life, people tend to ignore you. The systems tend to reject you, and then it's as if you lose your right to the dignity. And then you go through a lot of miserable suffering, a lot of avoidable suffering actually. And then I started considering it and decided that this is a place where a lot of input is needed, and this is a place where a physician can do a lot, and that's why I went into it. It's not on an emotional ground, and I believe that this is my lifetime commitment for me, and I believe that a lifetime commitment cannot be built on an emotional ground. It needs to be logical, it needs to be rational, and you need to be committed. So this is part of my philosophy.
Wonderful. Today, this morning actually, we had a very interesting conversation. If you remember, you said that actually every human being faces a crisis, and this crisis is the end of life, the crisis of death. And you mentioned that in your experience, thousands of patients that you have helped on this journey, and that probably only 1% of them have a happy death, or welcome, as you said, pass the test of death. Could you kindly elaborate on that?
Yeah, this is actually the quality of death, like quality of life, is a very subjective thing. Because when a person who undergoes it, if that person does not think that this is a good quality experience, so it's not poor quality at all, whatever you do, it remains a poor quality experience. So because it's very subjective, and this subjective factor, it actually depends on a lot of the way you live, your philosophy of life, the way you look at life and death. A lot of what we broadly call existential issues or spiritual issues are into it, and it's not easy to address from outside. So what matters ultimately is how other people perceive your life, how other people look at you. What matters ultimately is how you perceive your life. When you're looking back on your life, reflecting on your life, are you comfortable with it? Are you happy with it? And do you feel a sense of achievement, or do you feel a sense of dignity, a sense of respect, self-respect? So if you have that, you face death more comfortably, more peacefully, more courageously. But if you do not have that, you face death with the same amount of lack of confidence, lack of respect, lack of self-dignity. So this is important. So when you talk about this, is relevant when you look after somebody in the last few years of life, an elderly person, and then somebody with an advanced disease who is likely to die in a few years' time or a few months' time. One of the tasks that I believe is to make sure that this person looks at his or her life and also see it in an angle so that he feels like everybody might have had some accomplishments in life. Everybody might have had some value in life. So help them to discover that. Help them discover that, okay, after all, this is what I am. I'm not, now I may be an old person, now I may not be able to do a lot of stuff, but I just not the whole me. I've been doing certain things, I've been contributing, I've had my role, and I still hold that role. So this is important.
Right. Helping them come to terms with this, right? Helping them to look at life not as not just looking at all the lows, but also acknowledging the fact that before they became probably limited mobility, limited frailty might set in, as you're terminally ill, your physical body also starts to give. But before that, you were someone that was actively contributing to your family, to your community. So reflect on those positives as well.
Yeah, and especially, particularly look at the whole life. Not just this is what you are undergoing now is a difficult time in life, okay, but that's only part of your life. You had a lot of other things in your life. You as an individual, your life includes everything. So people lose sight of that. People tend to focus on this difficult time, tend to focus on the patient role, the dying person role, and then the society also looks at it that way. So the role of the healer or the treating team or the palliative care team will be to reorient the person, will be to help him or her look at the life as a whole, including the spiritual aspect, including the emotional aspect, including the achievements, including the life story, everything.
How would you help someone who is told that you've only 3 months left? How do you help them live? Because quality of life is important, but with that limited time,
there are a few things, like when actually if there is a existing good palliative care system, clinical system, they look after most of the physical symptoms. Actually, it's part of the last 3 months, and that's definitely needed. But then, more than that or above that, you need to have a purpose in life. If you do not have a purpose, like if you are living for 3 months just for living's sake, you become dejected, you become depressed, because there is no purpose in life. Even if you do not have a written, documented purpose in life, we all have certain goals and ambitions, and we look forward to the next day because there is something happening in the next day, or something that I can do the next day. So when you are diagnosed, or when you know that you have only a few months to live, you lose many of your dreams, you lose many of your projects, your hopes, your aims. But unless you replace it with something that is manageable, something that is tangible, you tend to live more like a vegetative way. So there is no dignity in it, there is no life in it. So that need to be addressed.
And how would you suggest a caregiver address this? Say someone who's caring for a loved one who's been told they only have 3 months left, and they are very depressed, right? I mean, immediately they'll always be this question about why me, God, why only 3 months? And as a caregiver, what can you do?
The caregiver also has a lot of stress, because an average caregiver is really stressed because the whole burden falls on him or her. But again, the caregiver also forgets that this person that they are looking after has had a different life altogether. So this is a different phase. So something that you need to remind yourself is that this person is not has reached this stage only recently, and he or she had a very, very active life, and that need to be reminded. And again, there are a lot of things which can actually elicit the self-response to life's worth, the life stories, sense of achievements, and the thing that has happened in the past, good memories, meaningful incidents, and these can be reminded and thought about and come back to this. And so this patient need to be able to reflect on this and realize that, this is what I am.
Right. There is one thing that we've recently done in Kampong Palliative Care, or KPC for short. We've been using VR as a way to have opportunities for those who are very chronic sick or on, afflicted with a life-limiting disease, and their caregiver is through VR, take them to a place that they've holidayed before, for example, or they like to do a walk on the beach, or maybe they went on a temple tour in India, visiting these places, VR allows that. It brought back moments of happiness because it's about recalling, good memories. So exactly like what you said, that, talking about the good experiences, that it was just this period of time that this person is very unwell and deteriorating. But if you look at the moment, your life in totality, there were also experiences and memories that they both cherish. And we've seen some traction in that, and was also very well received by both the caregivers and the patient. It wasn't a palliative patient, but someone with very limited mobility and multiple comorbidities with chronic illnesses. So it brought some relief.
Yeah, technology, particularly the virtual reality, so it's emerging now in a big way, and there's also it helps you to overcome some of the limitations of lack of mobility, because something you cannot go to a place, but you can still feel the sense of being there and the sensations of going through that experience. So it has a lot of options, but currently the problem that this is very expensive technology. The cost may come down in future, but I think this has a lot of an innovative in the hand of an innovative healer or a treatment system. VR has a lot of role in uplifting the spirit, in addressing some of these emotions and bringing back memories, and also like helping the patient to go through the past experiences and a lot of stuff. So this need to be, yeah.
No, certainly. I wanted to go back to personal struggles. What are some of the personal struggles that, in your experience, that a person who's been told that I don't have very much time left, what may be some of these struggles from your interactions with them?
No, this is actually, each individual is unique. You cannot generalize. You cannot the only way to look at it is to go through the patient's life story, because what shapes this moment, what shapes the reaction to this situation is very much dependent on what happened in the past. How this person was brought up, how the society was interacting with him, how he was interacting with other people, what are the social relationships, how connected is this person to people around them, and also his belief system, everything is there. So unless you are able to explore all this, you may not be able to suggest solutions or work with that person. Otherwise, this will be, if you generalize, like there's sometimes people just generalize saying that, okay, I offer this one, this work with one person. If something works with one person, it only means that it can work with that person.
Right.
So no generalizations is possible.
So it requires a lot of human touch, human connection, and the time to understand their life stories, their worries, what they hope for, before you can even offer some sort of support for them.
Yeah. Even listening to life stories is a good support, because you are encouraging the person to reflect on himself or herself. That can itself be therapeutic. And also knowing that, okay, there is a person listening to me, is also actually brings in certain amount of self-esteem. So, but you need to do it genuinely. You cannot just act to listen. You need to listen actively. So that itself is important. And also this will also give you hints as to what is important for this person. What are the hopes for this? What gives this person strength? What are the things that can still continue to give this person strength? So this is important. So, and this is something that you don't need a professional counselor to do that. It can be done by the neighbor, somebody, a friend, somebody close to the patient, because you are basically listening. And different from the professional psychologist or the doctor or nurse, this is more like a companionship. You are sitting with that person, helping that person go through the life history, life story, express himself or herself, think aloud, and then find some of the key points and reflect it back. And this is a sort of conversation which can be very rewarding.
Certainly. So one of the things that we've discovered also in this whole journey in our Kampong Palliative Care is deep listening is actually one of the skill sets that we hope to build in our community, because Kampong stands for community coming together. deep listening skills. And sometimes it's all right to say, especially someone who's grieving or someone who knows that a caregiver, that he or she has very little time with a loved one, sometimes just being present, because you just need another human being, just next to them. So sometimes just being there is as important, more important than doing things. Yeah. And this whole death literacy in Singapore is relatively low because we don't talk about death. Culturally, all our cultures, we don't talk about death. We celebrate birth, we celebrate marriage, but nobody talks about death. But there is a quality among Singaporeans that we can turn that to a strength. Is we're very pragmatic people. We are known for our pragmatism, and in that strength, by having conversations about death and dying and purposeful living, it's in a way helping people be more prepared, so that the preparedness will help them be less unclear or less troubled or less confused. Do you see value in that thinking?
Very often what happens is, like for example, something that has happened over the last 50 years, most places, is that the whole process of death and dying has become medicalized. And then when you look at dying, it's not a medical issue. It has a lot of social connotations, social issues, emotional issues, spiritual issues, and the hospital cannot address this wholly. Hospital can address the physical issue, but over the time, somehow earlier people used to die. Since people have been living, people have been dying, and the way societies or communities had their own ways of looking at it and their own ways of supporting and going through. And over the time, with this medicalization, communities become disempowered. The people, for example, when somebody is elderly or somebody is likely to die in a few months, people feel helpless, and they immediately rush to the hospital as if the hospital has an answer. So this is actually what the whole idea is to hospitals or the healthcare industry or healthcare system need to look at and address the physical symptoms and some of the emotional problems and some of these aspects. But the communities need to regain its role, because as a neighbor of the dying person, what should be my role? What should I be doing as a relative, as a family member, as a community member? So we had done that in the past, long time back, but we have sort of lost it, particularly in more advanced, more rich communities or high-income communities. They tend to lose it really fast. So they need to recapture that community spirit, the spirit of mutual support. And that's particularly needed when somebody is at the end of his or her life. That can be the main entry point. So this needs to be done. We are not rejecting the role of the healthcare system. We are saying that we need to supplement it with the community support and community participation and community engagement and the solidarity. Because this human being, the member of the community, is now undergoing a difficult time. You cannot just sit back and watch and let the hospital do whatever you want. You need to intervene actively. So this is what we think.
Yeah, that's what we hope with KPC, revive this community spirit. The fact that we're very pragmatic, have conversations when we are healthy, talk about what it means, because I think it's when we talk about death and dying, it brings you back to what kind of life you want to live, because you said dignity of life and dignity in passing, they are intertwined, they're actually different sides, two sides of the same coin. And that will help a society be more prepared, as individuals more prepared, and falling on your faith, it prepares you to manage the eventuality with more peace and a certain amount of dignity. Dr. Suresh, Kerala's model of community palliative care is recognized by WHO. What do you believe are the key principles and elements that make this model so effective and impactful?
So, it's not difficult. Actually, when you look at it, the basic principle is very clear and simple. Because the problem is universal. Universal in the sense that all of us will like to die. And 10% of us will die unexpectedly, suddenly, without any warning. So any period of bedriddeness or any dependency. But the other 90% will be dependent on others in the last few days, months or years. So the question is like, again, when you are dependent on others, if the others do not respond well, your life becomes miserable. And so the question that we ask people is like, don't you see this? Like, because people who are close to you, you yourself, will have to go through this. And unless we develop a system whereby we can do something to support these people, make this less miserable, you all also have to go through this. Or you have people who are close to, forget about the other people in the society, but you people who are close to you, people in your family, in your neighborhood, in your friend circle, will have to go through. So we tell people that this is our responsibility to build it. This is our responsibility to build a system, a safety net, which will protect people at the end of their life, make sure that they don't undergo unnecessary suffering. And because death is inevitable, but this suffering is avoidable. This is what we try to say, and this actually clicks, because you are not talking about a patient there, you are not talking about somebody else, you are talking about one's own life, one's own future, one's own fellow human beings, people who are close to them. So usually people understand. Then the question is, how can we do it? So then we talk about the different roles that you can play, and we talk about regaining the empowerment, regaining the community spirit, and we talk about caring as a skill. Because the basic argument is that in your lifetime you will come across somebody close to you going through this phase, and you need to know how to look after that person. So this is a skill that you can learn, a skill that you can apply. So this is the basic principle, and it works well.
Right. So one is about addressing the mindset, and secondly is equipping people with the skills to play this role, because it's a role that you would eventually, either today, tomorrow, or several years down the road, you would need to play in different capacity, as a friend, as a family member, as a former colleague, etc.
Yeah, and we notice that if you know what to do in a situation, you tend to behave differently as against if you do not know what to do. So we tell people that, okay, this is a real life situation you are going to face. Maybe your own family member, maybe your friend, or maybe somebody in your neighborhood, your old classmate. So you will be going through this, and you will be facing this. So if you know how to handle this, you won't panic. You will be useful to that person. You will be helpful. So then learn it. So this is basically what our whole argument has been, to build the skill and knowledge in the community, capacity building in the community, make sure that people know what to do, and then they will do it. This is what our experience.
Certainly. Maybe I'll just wrap up this interview, and I think this has been so exciting, and I'm sure our audience of the KPC channel really values some of these, I would say, gold nuggets, for them. And this is one of our outreach. While we do workshops and we do webinars, we also hope that the social media educational nuggets of information is also helpful. So let me wrap up with this last question for today. As a follow-up question, the Kerala model has had a very profound impact, I must say. And it's cited in certain literature for what Kerala has done. So beyond Kerala, where else in the world has your model taken root and flourished? And was there certain, you cannot take it and just apply it. Were there adaptations that needed in these countries?
Yeah, the basic principle is the same. The basic principle is inviting the community to fulfill its role, and capacity building in the community, teaching and training people, and then sort of hoping that they will fulfill their role. They usually do. But then different communities, different cultures, this need to be adopted and modified. So when we started in Kerala, there was a lot of resistance, not in Kerala, but from many of these established Western units and all. Because they were talking about palliative care run by the hospitals and the doctors only, and then nurses and other people. But over the time, this concept has gained acceptance widely. There are many places within India, like for example, Pondicherry, another state, Telangana, another state, Manipur, another state, Delhi, where this is being tried. And outside India, so some of the places like Sri Lanka has been experimenting with it, and some of the other countries, Bhutan, for example. And again, something that has happened drastically over the last 5-6 years is that earlier there was a belief that, okay, the rich, high-income countries do not need this sort of support, and then But now there is a leak thinking. I myself coordinated one program, community-based program in Switzerland, St. Gallen, one of the provinces, and UK, for example, St. Christopher Hospice, which is considered the first modern hospice in the world, is now experimenting with this idea. St. Joseph's, another hospice, is experimenting with this idea. A lot of 25, 30 sites have now come up with what we call compassionate communities. The same principle, like what can the community do to help this person? What is its role? Why should the communities, why should the healthcare and social welfare system work closely with the communities to make sure that the patient is comfortable? So this is coming up in a way. World Health Organization Southeast Asia Regional Office in its recent document emphatically said that without community participation, palliative care cannot be effective, irrespective of the rich or high income or low income country you are, because the healthcare system cannot cover a lot of, how can a healthcare system cover spiritual concerns and emotional support all the time and social support all the time? So an effective healthcare system can look after the physical component and some of the emotional component, but you need other people to do it.
Certainly. I mean, they are really overstretched. How much more can they do? I think we have to let them focus on the physical care. And I love what you said, and I think in summary for our audience, it's really about community coming back to regain, as you said, regain your voice and your right to play an active role in supporting every individual on this journey.
But particularly in communities with aging population, because how can you look after, how can the health and social welfare system look after all these people? Need round the clock care. For example, somebody with dementia, somebody with elderly, with decreased function. So how can you look after, and also can you do it effectively? Can you, is the system confident that we can address all these needs effectively and ignoring the community? It cannot do that.
No, certainly. And so this is the call to action, our KPC audience, that we all have a role to play. It doesn't matter how big or small, but we all have a role to play. And it's really about helping that person, giving the person the quality of life and the dignity in the last few days. Signing off, Swapna. Thank you very much, Dr. Suresh.